Hi, I'm Dr. Mike McInnes. I'm an internist. I'm one of the chief educators at Doctors in Training. I want to welcome you to set number 2 of the Part 1 questions. Remember, before you watch these video answers, you need to download the PDF of the questions, which you can find by clicking the link just below the video viewer. And you need to be sure to work through the questions before you watch these answers and look up any answers you couldn't come up with on your own. It's going to help you become more familiar with this material. So if you haven't answered these questions on your own, pause the video now and do that, then come back after you've answered the questions. So let's go ahead and get started with the first question. You have a patient who's experiencing progressive difficulty with swallowing liquids and solid food. Subsequently, the patient undergoes a barium swallow that reveals stenosis of the lower esophageal sphincter. What's the diagnosis associated with this barium swallow finding? Well, this is the classic presentation of achalasia, which is where the myenteric ganglia, also known as Auerbach's plexus, in the esophagus are destroyed, so the lower esophageal sphincter doesn't relax normally. Now, this results in the classic bird's beak appearance on X-ray. What are some common causes of this diagnosis? So most cases of achalasia are idiopathic, where there's inflammatory destruction of the ganglia, but we really don't know what caused it. You can also get achalasia secondary to Chagas disease, because the Trypanosoma cruzi organisms actually get in there and destroy the ganglia. With Chagas disease, you can see achalasia and dilation of the esophagus, or megaesophagus, as well as dilation of the colon, or megacolon. You can also have cardiomyopathy, which is a dilated cardiomyopathy. So you can remember that with Chagas disease, it's making everything enlarged. You have a big esophagus, big colon, and a big heart. And then other infiltrative diseases like amyloidosis and sarcoidosis can also destroy the ganglia and cause some achalasia. Next, in the lower extremity, what are some of the clinical differences between peripheral vascular disease or peripheral artery disease and deep venous thrombosis? So, who's hungry for alphabet soup? We've got PVD, PAD, DVT. So, PVD and PAD, same disease, two different names. This is atherosclerosis of the peripheral arteries. So you're getting ischemia of the muscles during exercise or during activity. This is claudication, which is like angina of the legs, or sometimes they can have it in the buttocks, the gluteals. So these are big muscles, and there's a lot of tissue that can get ischemic, and they can be painful. PVD will also cause decreased peripheral pulses or absent pulses, and the foot might be somewhat cool to the touch. And then the skin on the feet and the lower legs can become pale and shiny and even relatively hairless, because if the skin's not getting good circulation, it's not going to waste resources making leg hair. So if you see a patient, especially a man, who has hairy upper legs and then no hair below the knees, think about the possibility of PVD. Then a DVT is a blood clot that forms in a peripheral vein, often because of immobilization. Now with DVT, the leg is likely to be relatively warm, not necessarily warmer than any other part of the body, but warmer than the cool foot we saw with PVD. The affected leg will often have an increased calf circumference. The calf can be tender when you compress it, which is called a Moses sign. There's also a sign called Homan sign, which is where you dorsiflex the ankle, and that's supposed to elicit calf pain. Now, Homan sign is notoriously insensitive, but it's still one of those classic signs to be aware of. Next, a 22-year-old man suffers a stabbing injury to the chest. He's lost a lot of blood, and you're concerned that his cardiac output is low. So, what are the two equations for cardiac output? So the first equation is cardiac output equals stroke volume times the heart rate. Now for me, that's the easiest one to remember and understand, although it's not terribly clinically useful because you can't really measure the stroke volume easily. And the second equation is cardiac output equals the rate of O2 consumption divided by the difference between the arterial and venous oxygen content. Next, a 66-year-old man currently taking warfarin for atrial fibrillation is instructed to avoid food products that contain vitamin K to optimize anticoagulation. For what coagulation factors is vitamin K necessary? Now, our mnemonic for this is DISCO started in 1972. So 1972 is going to help you remember that the vitamin K dependent coagulation factors are 10, 9, 7, and 2. And then the S and C in DISCO remind you that vitamin K is also important for the synthesis of protein S and protein C. Next, your 46-year-old male patient is asking your advice on whether to take a daily aspirin. How does taking an aspirin a day prevent platelet aggregation and myocardial infarction? Now, aspirin permanently inhibits this enzyme cyclooxygenase, both COX-1 and COX-2. So that's going to lead to less production of thromboxane A2. What does thromboxane A2 do? Well, one thing it does is promote platelet aggregation. It's thromboxane, and it promotes thrombosis. So aspirin inhibits cyclooxygenase, so you're going to have less thromboxane, and therefore less platelet aggregation, less thrombosis. And then which two arachidonic acid products affect platelet aggregation? Well, we just said that thromboxane A2 stimulates platelet aggregation. And then prostacyclin, which is PGI2, inhibits platelet aggregation. Next, a 5-year-old boy is treated with mebendazole for a pinworm infection. Mebendazole acts on the microtubules to inhibit the pinworms. What other medications act on microtubules? So there's griseofulvin, which is an antifungal drug. There's vincristine and vinblastine, which are both anti-cancer drugs. There's paclitaxel and other taxols, which are also used in the treatment of cancer. And then there's colchicine, which is used occasionally to treat gout. And then what syndrome demonstrates a defect in microtubule polymerization? Well, this is an immunodeficiency disease called Shade-Higashi syndrome, which is where the macrophage's microtubules don't function properly, so they're not able to perform phagocytosis. And then the patients are going to get recurrent pyogenic infections, peripheral neuropathy, and also partial albinism. Next, thiazolidine diones, or TZDs, increase expression of one type of GLUT receptors, those in the adipose tissue, as one of their anti-diabetic actions. Which GLUT receptors would you expect to find on skeletal muscle and on fat? So these are the GLUT4 receptors, which are insulin-dependent glucose receptors. That's why insulin is required to transport glucose into skeletal muscle cells and adipose tissue, because of those GLUT4 receptors. Next, what is compartment syndrome and how is it treated? Well, compartment syndrome is where you have some kind of injury to the leg usually, like trauma or a burn injury or even just intense exercise. So when you have this injury, the tissue starts to swell, and that increases the pressure within the fascial compartment of the leg. And it can actually squeeze the nerves and the vessels and cause vascular compromise. So it's very, very important to recognize this quickly. And then you treat it by performing a fasciotomy, where you make an incision on the overlying fascia to relieve the pressure in that involved compartment. Next, an 18-year-old woman has seasonal allergies. She complains that her eyes water and her nose runs constantly during the spring. Which cell type is responsible for her symptoms, and what drug inhibits these cells' action? So the cell type that's immediately responsible is the mast cells, because they release histamine and other chemicals that dilate the capillaries and attract other inflammatory cells. Then the drug that directly inhibits the action of the mast cells is called cromolyn sodium. It stabilizes the cell membrane of these mast cells so that they can't release their granules of histamine. So cromolyn prevents mast cell degranulation. Now, you may have also been thinking about antihistamines, things like diphenhydramine or loratadine, because those are actually much more commonly used to treat seasonal allergies and treat allergic rhinitis. But those aren't really directly inhibiting the mast cell's action. They're just blocking the downstream effects of histamine. So that's a very high yield, important point to remember for your exam. They're going to try to trick you on the mechanism of action of cromolyn sodium and of antihistamines. But if you remember the basic concept, you can get that question right. And then the second part of the question is, what white blood cells descend from the myeloblast or granulocyte lineage? So these are the neutrophils, the eosinophils, and the basophils. Now, mast cells are similar to basophils, both in terms of function and in terms of appearance, but mast cells actually come from a different cell line. Basophils, these granulocytes called basophils, are found in the blood, and mast cells are mainly found on the mucosal surfaces and in connective tissue. And then the last question, which GI ligaments match the following descriptions? So the ligament that separates the greater and the lesser sacs of the peritoneal cavity are the gastrohepatic ligament and the gastrosplenic ligament. The ligament that may be cut during surgery to access the lesser sac is called the gastrohepatic ligament. Two ligaments that connect the spleen to other structures are the splenorenal ligament and the gastrosplenic ligament. The ligament that contains the portal triad is the hepatoduodenal ligament, and then connects liver to the anterior abdominal wall is the falciform ligament. All right, that does it for question set number 2. I'll see you next time.